So today we'll talk about the respiratory distress and pulmonary failure. So we'll review the initial assessment of the patient in respiratory distress, review the management of a specific cause of respiratory distress, upper airway, lower airway obstruction, lung tissue disease, and disorders of control of breathing. And in the end, we'll talk about the pulmonary failure and its management. So to start with, we'll discuss the initial management and steps of management in the respiratory distress. So the initial, there is a rapid assessment in which we need to quickly determine the severity of the respiratory condition and stabilize the child, and respiratory distress can quickly lead to cardiac compromise. So airway, breathing, and circulation should be assessed, and these should be optimized. History of and physical examination should be done with a special emphasis on quick physical examination and management as per ABC protocol. In the meantime, we have to apply pulse oximetry, arrange for the chest x-ray, and take the bloods and send it to the lab to analyze for any abnormalities. So we'll discuss a few examples as we go along. So the life-threatening conditions include complete upper airway obstruction, respiratory failure, which we'll discuss at the end, tension pneumothorax, pulmonary embolism, and cardiac tamponade. So specific causes include the upper airway obstruction, lower airway obstruction, lung disease, disordered control of breathing. The upper airway obstruction, the causes are foreign body tissue edema, trauma, viral infection, and it produces the symptoms of the partial obstruction, noisy inspiration, stridor, choking, and gagging, and complete obstruction with no audible speech. Management include rapidly to decide and advance the airway as needed, avoid agitation, and treat the crew and anaphylaxis if required. Lower airway obstruction include bronchiolitis, which is due to infection, asthma, which with the symptoms of wheezing and tachypnea, and can be assessed with the severity. Is it mild to moderate, moderate to severe, or impending respiratory failure is there. Lung tissue disease could be infectious, aspiration related, ARDS, that is a non-cardiogenic version, and the cardiogenic version of the pulmonary edema. Consider giving the positive expiratory pressure, CPAP, BiPAP, or mechanical ventilation. Disordered control of breathing, the abnormal respiratory pattern produces inadequate minute ventilation, altered level of consciousness, elevated intracranial pressure, poisoning or drug overdose, hyperammonemia, metabolic acidosis, neuromuscular disease, restrictive lung disease, and support oxygenation and ventilation while treating the underlying problems. So we'll come to the respiratory failure and discuss. So the respiratory failure may occur as a secondary dysfunction in ventilation of intrapulmonary gas exchange, gas transport, or tissue gas exchange. It may occur independent of the cardiac performance. The mechanical ventilation strategies have been shown to improve the intrapulmonary gas exchange. When the pulmonary failure is refractory to these maneuvers, the techniques of extrapulmonary gas exchange are required, as seen in the extracorporeal membrane oxygenation and the pumpless extracorporeal lung assist device. The assessment of the minute ventilation provides a critical insight into the adequacy of the mechanical ventilation. The minute ventilation or is calculated with the respiratory rate into tidal volume, or the CO2 removal is also the assessment of the function of the respiratory rate and tidal volume. Therefore, the blood gas parameters that measure CO2 removal, PaCO2, and pH are the best determinant of the adequacy of the rate and the tidal volume. The spectrum of the pulmonary failure represents the hormonal, parenchymal, and the bronchial response of either the primary pulmonary insult or the secondary systemic disease. The phases of the injury include the edema, in which there is increased lung water and decreased compliance proliferation with the increased cellular response of the injury of the macrophages and the neutrophil migration, and fibrosis, which is later and usually irreversible. The refractory hypoxemia occurs when the fluid or the cellular infiltrate causes the alveolar flooding or collapse, and there is a peribronchial edema, VQ mismatch, and microatelectasis leading to major atelectasis. The alveolar capillary membrane is injured either at the alveolar space, could be due to smoke, inhalation, aspiration, or the blood membrane side, that is the sepsis or fat embolism. An increase in the membrane permeability results in the protein-rich fluid accumulating in the interstitial and alveolar spaces, such as fluid inhibits surfactant, contributing to widespread microatelectasis. The fluid-filled alveoli do not open and do not participate in gas exchange, and there is a heterogeneous distribution of the alveoli and the various degrees of compliance. In the later stages, increased PVR and pulmonary hypertension may occur. The acute or adult respiratory distress syndrome is the most severe form of the acute lung injury, and it represents a non-cardiogenic pulmonary failure. Thus, it is characterized by acute onset of the symptom and the presence of the bilateral infiltrates and the pulmonary capillary wedge pressure less than 18 millimeters, and the ARDS represents the significant inflammatory response to the local pulmonary or remote systemic insult, which results in hypoxemia and marked alteration of the pulmonary mechanics. The degree of hypoxemia distinguishes ALI from ARDS. So in ALI, PaO2 to FiO2 ratio is less than 300, whereas in ARDS, PaO2 to FiO2 ratio is less than 200. The PaO2 or FiO2 ratio is the reflection of the shunt fraction through the lungs and thus the barometer of the gas exchange. In the acute lung injury, we have to take in consideration the acute lung injury score, and it can be used in adult patients to assess for the extent of the acute pulmonary drainage damage, and it may be used both at the onset of the lung disorder or during the course of the illness, or to monitor the changing lung environment. The parameters of the acute lung injury scores include chest X-ray evaluation for alveolar consolidation, PaO2 to FiO2 ratio, PEEP level if ventilated, and the respiratory compliance. The range of 0 to 4 point on the allocated for each category, with the score of 0 indicating no lung injury and a score of 0.1 to 2.5 indicating a mild to moderate lung injury, and a score of more than 2.5 indicating a severe acute lung injury, with a ratio of less than 300 and ALI, and there is increased mortality, and the ARDS with ratios of less than 200, there is a predictive mortality of 40 to 50%. The high mortality is caused by multiple organ failure, sepsis, and stroke, MI, progressive pulmonary failure. The infections with variant swine and avian flu and other viruses have included the rapidly progressive lower respiratory tract disease, and with the onset of coronavirus, we have seen a lot of patients requiring the pulmonary failure management and development of ARDS. And these cases have increased the need for advanced pulmonary support in the patient that are often young and lethally diseased. algorithms for advancement of the management of the refractory ARDS with the ventilatory strategies and the mechanical assessment have been forged based on the experience of the management of the patient. So the treatment strategies to prevent the fibrosis is by decreasing the edema and proliferative phase while supporting the gas exchange in injured alveoli. The conventional volume cycle mechanical ventilation can result in alveolar injury due to barotrauma and volumotrauma. And as such, the lung protective ventilation causes the pressure volume ventilation management, where the goal is to maintain the opening and pressures of the alveoli and while not exceeded the distension. Um, the lung protective ventilation uses the pressure volume ventilator management, where the goal is to maintain the opening pressures of the alveoli while not exceeded the distension barotrauma tolerated by the alveolus to achieve the gas exchange. So there are a few important considerations. The standard care of ARDS include the mechanical ventilation using the least FiO2 necessary, optimization of the perfusion with the goal of oxygen delivery and consumption, 2:1, hemoglobin more than 10, and inotropic support, correction of the volume status, which diuresis or continuous renal replacement therapy, nutritional support with adequate nitrogen balance with preference for enteral feeding, paralytics, and prone positioning. If this initial measure fails, then the maneuvers include the advanced mechanical ventilation and extrapulmonary gas exchange with ECMO and PECLA, and both ECMO and PECLA are being increasingly introduced in critical care settings as a rescue therapies in patients who fail to respond with the conservative measures. Thank you.